Assalamu alaikum everyone. In today's video lecture, we'll be learning about applications of pharmacokinetics under the codes of biopharmaceutics and pharmacokinetics. Let's start. So, individualization of drug dosage regimen. Uh, Knowledge of pharmacokinetics can be utilized in individualization of any drug dosage regimen. So, not all drugs require a rigid individualization of the dosage regimen. Many drugs have a large margin of safety, that is, exhibit a wide therapeutic window, and strict individualization of the dose is unnecessary. So, for drugs that are having wide therapeutic window, like for example, paracetamol, aspirin, okay, and for this drug, usually strict individualization of the dose is not necessary. The US FDA have approved an over-the-counter classification for drugs that the public may buy without prescription. So for these drugs, actually, individualization is not necessary. In the past few years, many prescription drugs like ibuprofen, loratadine, omeprazole, naproxen, nicotine patches, and others have been approved by the FDA for OTC status. These OTC drugs and certain prescription drugs, when taken as directed, are generally safe and effective for the labeled indication without medical supervision. So, for these conditions, usually individualization of the drug dosage regimen is not required. So, for drugs that are relatively safe and have broad safety dose range, such as penicillin, cephalosporin, tetracycline, antibiotic doses is not titrated precisely, but is based rather than on clinical judgment of the physician to maintain an effective plasma antibiotic concentration above the minimum inhibitory concentration. For drugs with a narrow therapeutic window, such as digoxin, aminoglycoside, antiarrhythmics, anticonvulsants, and some antihistamines such as theophylline, individualization of the dosage regimen is very important. So we can easily understand that uh, for drugs with narrow therapeutic window, okay, those drugs which are seems to be very having very narrow therapeutic index, for this drug individualization is very important. The objective of the dosage regimen design for these drugs is to produce a safe plasma drug concentration that doesn't exceed the MTC or fall below the MEC. For this reason, the dose of these drugs is carefully individualized. For drugs such as phenytoin that follow nonlinear pharmacokinetics at a therapeutic plasma drug concentration, a small change in the dose will cause a huge increase in the therapeutic response, leading to the possible adverse effects. So, for all of these drugs, usually individualization is very important. Now let's discuss the design of a dosage regimen. So how utilizing the pharmacokinetic knowledge we will uh, design a dosage regimen. So several methods may be used to design a dosage regimen. Generally, the initial doses of the drug is estimated using average population pharmacokinetic parameter obtained from the literature. The patient is then monitored for the therapeutic response by physical examination and, if necessary, by measurement of serum drug levels. After evaluation of the patient, adjustment of the dosage regimen using the patient's individual pharmacokinetic parameter may be indicated with further therapeutic drug monitoring. Many versions of clinical pharmacokinetic software are available for dose calculation of the drug with narrow therapeutic index, for example, data kinetics and the Abbott-based pharmacokinetic system. Then, individualized dosage regimen. The most accurate approach to dosage regimen design is to calculate the dose based on the pharmacokinetics of the drug in the individual patient. This approach is not feasible for calculation of the initial dose. However, once the patient has been medicated, the readjustment of the dose may be calculated using pharmacokinetic parameter derived from measurement of the serum drug levels from the patient after initial dose. Most dosing program record the patient's age and weight, calculate the individual dose based on creatinine clearance and lean body weight. So dosage regimen based on population average. The method most often used to calculate the dosage regimen is based on average pharmacokinetic parameter obtained from clinical studies published in the drug literature. This method may be based on a fixed or an adaptive model. The fixed model assumes that population average pharmacokinetic parameter may be used directly to calculate the dosage regimen for the patient without any alteration. So um, in fixed model, as the name suggests, no alteration uh, is being performed. Usually pick up parameters like absorption rate constant, viability factor f, apparent volume of distribution vd, and elimination rate constant k are assumed to remain constant. Okay, these parameters remain constant, so these are defined by the fixed model. Most often the drug is assumed to follow the pharmacokinetics of an one compartmental model. The practitioner may use the usual doses suggested by the literature that makes a small adjustment of the doses based on the patient weight or age. Now let's discuss the adaptive model. So it uses patient's variables, okay, such as weight, age, sex, body surface area, and patient's bio pathophysiology or renal disease, or also as well as the known population average pharmacokinetic parameter of the drug. So actually these parameters are very much variable, okay, because weight is changed time by time, then age is also changing, okay. So body surface area, it also changes due to some increasing or decreasing of weight. So a lot of variables, okay, these variables are seems to be following the adaptive model. In this case, calculation of the dosage regimen takes into consideration any changing pathophysiology of the patient and attempts to adapt or modify the dosage regimen according to the need of the patient. So dosage regimen based on partial pharmacokinetic parameters. For many drugs, the entire pharmacokinetic profile for the drug is unknown or unavailable. Therefore, the pharmacokinetist need to make some assumption in order to calculate the dosage regimen. For example, a common assumption is to let the viability factor equal to 1. Okay, so in upcoming lectures you'll see whenever we are performing any solution of the problems, we sometimes take the f as 1, okay, or 100%. Thus, if the drug is less than fully absorbed systematically, the patient will be under medicated rather than over medicated. Some of these assumptions will depend on safety, efficacy, and therapeutic range of the drug. Then empirical dosage regimen. In many cases, the physician selects a dosage regimen for the patient without using any pharmacokinetic variable. In such a situation, the physician makes the decision based on the empirical clinical data, personal experience, and clinical observations. So, another application of pharmacokinetics is it can be utilized. Its knowledge can be utilized in empirical dosage regimen design. Okay, the physician characterizes the patient as representative of similar well-studied clinical population that has used the drug successfully. Now, one of the most important concept is the conversion from intravenous infusion to oral dosing. This conversion is very important because whenever the patient is uh, parenteral or IV administration is taken out, then obviously he needs an oral dosing, or sometimes parenteral administration cannot be performed. Okay, or sometimes oral dosing needs to be converted into an intravenous infusion, whatever the situation is, but we need to learn the conversion from IV infusion to oral dosing. Okay, so after the patient's dosing is controlled by IV infusion, it is often desirable to continue to medicate the patient with the same drug utilizing the oral route of administration, because yes, it's time for going home. Yes, his medication or therapy has been fully performed, but sometimes it's also necessary to deliver the dose. Okay, but it's very difficult to deliver the IV infusion in your home setup. Okay, because ICU setup or those CCU setup is not so much convenient. Okay, the setup which you will get in the hospital would not be so convenient in your home. So that is why sometimes whenever a patient is taken out of the uh, operation theater or any other ICU or CCU or any hospital, okay, IV infusion, whenever he is taken out of there, then yes, at the time of going home he's rendered a oral dosing or oral doses from. Okay, so you need to learn about in which dose he need to deliver the therapy. Okay, so that is why we need to learn the conversion from IV infusion to oral dosing. So when IV infusion is stopped, the serum drug concentration decreases according to the first order elimination kinetics. So we have already studied this in our previous lecture of compartmental modeling. For most oral drug product, the time to reach steady state depends on the first order elimination rate constant for the drug. Therefore, if the patient starts the dosage regimen with the oral drug product at the same time as the intravenous infusion is stopped, then the exponential decline of the serum level from the intravenous infusion should be matched by the exponential increase in the serum drug level from the oral drug product. Yes, its steady state drug concentration is getting decreased. Yes, yeah, that was our situation. Whenever his dose has been stopped, it would decrease exponentially. Okay, but in the meantime, he needs to maintain his steady state concentration or something like that. So at the same time, what he need to do, he need to obtain a dosage form. This is oral dosage form. Okay, this is the step of the IV dosage form from where oral dosage form should be started. So this is the case. The conversion from the intravenous infusion to controlled release oral medication give once or twice daily has become more common with the availability of more controlled release drug products such as theophylline or quinidine. We'll discuss this in the controlled release delivery system. So how would convert this? Okay, utilizing this formula, you can easily convert the IV to oral administration. So method one assumes that the steady state plasma drug concentration (CSS) after the IV infusion is identical to the desired C infinity average after multiple oral doses of the drug. Okay, C infinity average is the concentration of the oral dose. Then S means the salt form of the drug. Okay, then d naught by tau. D naught by tau is the dosing rate. Okay, you can see here d naught by tau. Then kvd, you all already know the kvd. K is the elimination rate constant, where vd is the volume of distribution. So by utilizing this equation, yes, you can see you can have some you can have some components or parameters regarding to the IV infusion. You can also have some parameters regarding to the oral doses from. Okay, so this equation is very important. You can also see a math regarding this. So here is the math regarding the problem. An adult male asthmatic patient has been maintained on the intravenous infusion of the immunophilin at the rate of 34 milligram per hour. So at the rate means they have already given you d naught by tau. D naught by tau. This value has already been given. The steady state theophylline concentration was 12 and the total body clearance was calculated to 3. So total body clearance means it is nothing but kvd. The value of kvd is equal to body clearance. Then theophylline concentrations infinity average has been already been given. Now infinity average has already been given. So I think that becomes very easier for you because they ask for calculating an appropriate oral dosage regimen. Okay, uh, oral dosage regimen means you have to calculate the dose of the drug, okay, with its frequency. Just go through this, you can easily calculate this. This is the salt form of immunophilin, 85% of theophylline, so it is 0.85. S is equal to 0.85, then you just put the value taking the F as 100%. So after performing the math, we find out the value, that is uh, 28.9 milligram per hour. So let's see the discussion. Our dosing rate was 28.9. So the theophylline dosing ratio of 28.9 must be converted to a reasonable schedule for the patient, because the patient may take the drug as after 12 hour or after 8 hour or after 24 hour, whatever the situation is, we need to design the dose. So therefore, the total daily dose is 28.9 into 24 hour, or 693 milligram per day. Possible theophylline schedule might be 700 milligram per day, or it can be also 350 milligram every 12 hour, or it can be also 175 milligram every 6 hour. Okay, you can also measure it for 8 hour. It may be 220 or something like that. So each of the doses regimen would achieve the same C infinity average but different Cmax and Cmin. Okay, which should be calculated. Then it would be converted into multiple doses regimen. Okay, we have already studied this. The multiple doses regimen, it would be like this. Okay, multiple doses regimen. You will have this curve. The dose of the 350 milligram every 12 hour could be given in sustained release dosage form to avoid any excessive high drug concentration in the body. So you need to write all of this. There is another method for doing this calculation. Just go through this. So this is all from our application of pharmacokinetics under the course of biopharmaceutics and pharmacokinetics. If you have still any confusion, please inform me in the comment section. Thank you.